Okay, we are live. This is Dr. Michael Kaye from the Center for Functional Health, and today I'm honored to have with me a very special guest, Dr. Chopra. Thank you very much for taking time out of your busy schedule and coming to do this question and live podcast, right? So this is really cool because we're going to be talking about sleep. And sleep is so elusive for many. We're told that we need to get a good night's sleep, but many of us are not getting a good night's sleep. And we know without sleep, it affects our musculoskeletal system, it affects our heart, it causes poor health, it affects our metabolic system. So, welcome, welcome. It's great to have you. And today I want to dive deep, no pun intended, into sleep.
Oh, thank you, Michael. I'm excited to be here today and chat about something that we do all the time and to sort of shed some light and demystify some of the concepts of sleep that might be out there.
Fantastic. So before we dive in deep, can you share with us your background? I know you did pulmonary medicine, I think critical care as well.
Yeah, I have pretty humble beginnings. I'm an internist by training, did residency at UCLA, and then I worked as a hospitalist for a few years before specializing in pulmonary critical care medicine, which I had the opportunity of doing at Loma Linda University. And during that time, became really interested in sleep medicine um, from a wellness and health standpoint, and ended up doing a sleep medicine fellowship in Boston at Harvard. And ever since then, it's kind of been no looking back.
And but what drove you to sleep medicine? You were in pulmonary medicine, all that kind of stuff, but there's something that must have drawn you into like, wow, if without sleep, we just really can't move forward. And we see that in the practice, right? We can do all the right things, you can eat right, you can exercise right, but without sleep, you're just not moving that optimization of life forward. So what made you drive into sleep?
I think it was a couple of things. In fact, it's actually quite common for people who are pulmonologists to do sleep medicine.
Mhm.
The reason is there's a breathing condition called sleep apnea. It's basically unhealthy breathing during sleep. Uh, and because of that being such a common condition and problem, it's not uncommon for people who have pulmonary backgrounds to do additional training in sleep medicine. That was one. The other thing that also sort of like coincidentally happened is Loma Linda is a blue zone.
Mhm.
A blue zone is an area in the world where the WHO has sort of said that people have a longer life, longer lifespan, possibly health span, and uh, Loma Linda had kind of a unique wellness vibe to it from that standpoint, and because we were seeing a lot of patients who had pulmonary breathing sleep issues like sleep apnea. I just became very curious in the world of sleep, sleep science, and wanted to learn more.
Very cool. And when most people talk about sleep, they know this basic REM, this REM sleep, right? And this rapid eye movement. We dive a little bit deeper into a little bit of the science of sleep. So it's more than just rapid eye movement. There's much more to it than that.
Yeah, totally. And yeah, like we'll just take maybe it makes sense to take a step back. There's sort of like two processes at play for this idea of sleep. One is like this circadian rhythm process where our body has a daytime and it has a nighttime. We want our opportunity of sleep to coincide with our body's nighttime. We don't want to consume sleep during our body's daytime, otherwise, there would be a big misalignment. Sort of shift work is a good example of this.
Mhm.
So, when we think about sleep, we're thinking about circadian rhythms as well as what happens to your physiology when you sleep. And what you're referring to, or when patients refer to from like the sleep stages standpoint, where there's two stages of sleep, REM sleep, where there's rapid eye movement sleep, the brain is kind of awake, but the body is paralyzed. And then you have non-REM sleep, non-rapid eye movement sleep, where the brain is sort of like in this distant, unconscious, lack of recollection sort of space. And that's what we usually sort of qualify as light sleep, deep sleep, in non-REM sleep, and then you have REM sleep, which is rapid eye movement sleep, that happens during the night.
Okay. So we see a lot with the night shift workers. They are more prone to cardiometabolic disease. So what is the thought process that they cannot sleep, they're working through the night. Something's happening on a physiological level that makes them more prone to these types of dysfunction. I think one of the studies actually said that, and you can talk to us please, if that they're more prone to like a cancers as well because they're not getting to sleep. What is occurring physiologically, in your opinion, that kind of makes them more prone to these types of dysfunctions?
Yeah, I think it's a little bit confusing. Um, the what we do know is people who have complete sleep state, sleep circadian misalignment, like a shift worker, and we know this from like the nursing cohort out of Wisconsin. Um, the prevalence of breast cancer is higher in night shift working nurses. Okay.
Hmm.
And we think that it has to do with circadian rhythm disruption. Different genes are working different, different genes are operating at different levels at different times of the day. So if sleep is the opportunity for housekeeping and restoration, and if that process of restoration is broken, and malignancy or cancer is the inability to um, program it's unprogrammed, or it's uh, uncontrollable cell proliferation. Well, if there is going to be sleep disruption, then one could be at a higher risk of developing different kind of malignancies, and breast cancer has been an example that has been shown.
And it's so hard because we really can't move away from that night shift work. That plays a an amazing role. I mean, we can't move away from it. So, is there something that can be done to kind of thwart the process that occurs when we can't get to sleep from the cell proliferation perspective? I mean, what can be done? How can one better themselves? I mean, we can talk about taking a B vitamin, all that. That's fine, nutrition, but how does one really protect their physiology? What can they do during their time when they're awake, and what can they do aside from coming home, sleeping, making the dark room and the environment right? You can't bank sleep, correct? So what can one do?
It's a tough situation. I don't think there's a good solution, but I think one like uh, strategy to approach this is to sort of see like how high risk are you to develop malignancies, and if you are someone who is high risk to develop malignancies, depending on different blood-based genetic tests, then one can do a risk assessment of like maybe I'm at a higher risk because I am at a higher risk of developing cancer of this type. Maybe I want to be more thoughtful of how my circadian rhythms are operating. Again, this is my personal opinion. I'm not
Mhm.
speaking from the
Right.
literature by any means, but that I think could be an intelligent way to approach this. But right now, there's really no good solution. Shift work is like difficult. There are medications to help you sort of get through the night. That are wake promoting medications that are stimulants, but it's always a struggle. There's really no good solution for shift workers.
I try to tell, I times we'll get the young shift worker to say, it's great to do this in your 20s, but by 30s, you got to start thinking about something different because we get away with so much physiologically, immunologically, neurologically when we're younger. That bounce back, that resilience is great. So I always say, like, if you're doing this shift work and they're making the differential, so they're making more money, right? So it's wonderful. But then there's just, that physiological time where it's like, hey, you know what, you're hitting the top, try to think about moving that shift to somewhere else, just from a health perspective.
Totally,
So,
100%. Could not agree with you more.
one of the things that we see in the office quite a bit is patients who complain of insomnia. And it is so hard, it seems so lately, to get, into the pulmonologist, in to make the sleep study. And a lot of people are really affected by not sleeping. So if we can look at the different types of insomnia, if you can talk about that a little bit, that would be great.
Insomnia. So the way to think of this is insomnia essentially refers to the difficulty with sleep onset, difficulty with sleep maintenance, or unwanted early morning awakenings. And if these symptoms cause dysfunction during the day. And that dysfunction could be in the form of fatigue, the propensity to take a nap, brain fog, cognition, irritability, anxiety. It could be a variety of things. And symptoms of insomnia could either be sort of acute, like less than 3 months, or they could be chronic, more than 3 months. And when we're talking to patients who have insomnia, what we're really trying to figure out is what kind of insomnia do they have? And like how long has it been going on? And is there something that could be driving it? Like what's the root cause of it? Is it a medication that there was it where they just started on a beta blocker a few years ago and like that's what triggered it? Or there was some kind of a life event, that a death in the family, somebody got sick, um, that could have triggered it? Do they have other medical conditions like restless legs, that could make it difficult for them to fall asleep? Or do they have a circadian rhythm problem that is making it difficult for them to fall asleep at the right time? Or perhaps they have just acquired a series of bad maladaptive behaviors. I hear this term often, doom scroll, like people on
Yes.
their phone, just scrolling until they can't fall asleep. And so I think that like insomnia is such a the term gets thrown around. Uh, like I have insomnia, but there's like so much more that needs to be dissected out of that story to figure out what's going on, how long has it been going on, what's insomnia to you, and then sort of try to figure out what do we think is the root cause, and then try to address that accordingly. But like
Gotcha.
this idea that I have insomnia and I need a medication, or I have insomnia and I need a supplement, like that's not a very it's kind of a knee jerk approach. I'll put it that way.
Right. But it's often typical, right? So a patient comes in with X and we write a script for it, and it's simple, right? So it's a pill for every ill and a supplement for every symptom, right? And it doesn't get to the root cause either way. So, but we will see, we have a group of people like our female patients, and they will often say, "Hey, listen," they go to sleep, and around 2 or 3 in the morning, their eyes pop open, and then the act of rumination begins to occur. And for a lot of our older gentlemen, the prostate wakes them up. They'll get BPH, doing prostate issues, they got to urinate. So this also disrupts sleep. So I agree with getting to that root cause of it. What is really driving that sleep, and that's why I'm really looking forward to when we look at what your company actually does, because I really honed in on that sleep fragmentation. We'll get to that. So when people are tired, they go for coffee, right? That's the Red Bulls, all that caffeine, and we know caffeine affects the adenosine. Can you talk a little bit how caffeine may not be the answer to getting somebody to stay awake, and maybe working on different types of things to help them stay more alert?
Yeah, it's kind of a deep question. And again, this is assuming someone is a good sleeper. Let's assume if some let's like, I guess let's do both things. Let's assume someone's a bad sleeper. In that situation, the first step needs to be like we need to figure out why somebody isn't sleeping well. And if we figure out why they're not sleeping well, may they, as a byproduct of better sleep, they may not need as much caffeine the next day or stimulant the next day. And if they have less stimulants, they will then sleep better the coming night. So it's a self-fulfilling feedback loop. If you have somebody who, let's say, sleeps well and is consuming excessive amounts of caffeine, you sort of alluded to this. Like adenosine is a molecule that builds up in the brain over the course of period of wakefulness, and caffeine inhibits it to allow us to feel less sleepy. And so it acts as an antagonist, as a blocker to adenosine. And when we sleep, adenosine levels drop. It gets filtered out of the brain, so to speak, and then we wake up in the mornings, hopefully less fatigued and more rested. Um, Everyone processes caffeine with different over a different period of time. Some people metabolize caffeine slowly. Some people metabolize it faster. But generally speaking, having caffeine prior to bedtime will reduce the amount of deep sleep one has, generally speaking, and it will increase the amount of fragmentation one has, generally speaking.
Right. And I try to tell folks that, when you drink coffee, coffee isn't giving you energy. You just become not tired. Right. So there's two different things. You're just not tired. It doesn't necessarily mean you have the gumption to do more. You're just not tired. And like you said, there are people who they can have an espresso, right before bed. And, if I don't finish my coffee by noon, I'm up that night. Right. So, that definitely plays effect. So can we talk a little bit about alcohol? Because a lot of people say, oh, I like to have that nice glass of wine night that helps me sleep, but it really doesn't help them sleep per se. Is that correct?
Yeah, no, it's a good question. Like we've all used this, we've probably all have heard this term nightcap, you know, prior to bed, and anecdotally, the literature is pretty consistent that people's sleep is worse with alcohol. The quality of sleep that they have with alcohol, although it can help them fall asleep faster, sleep onset can be shorter, but the amount of deep sleep and quality sleep that they have is usually less with alcohol as compared to no alcohol. And but surprisingly, I've actually seen a couple of people now who just metabolize alcohol in phenomenal ways, and
Mm.
like they don't, their sleep is not as dysfunctional with alcohol as one would expect it to be. The other interesting thing that we've observed, again, I'm just sharing my anecdotal experiences here, is different alcohols influence different individuals differently. So like a wine versus a clear liquor versus a brown liquor versus beer, um, different people respond differently to these different forms of alcohol, and like sleep can be different too. And the other thing that sort of could be taken into account here, if we get into the details, is like the timing of alcohol, because rule of thumb generally has been you want to give yourself 1 hour before sleep for every drink you've had, roughly. So if you've had like two drinks and you don't want it to influence your sleep in a substantially negative way, then give yourself about 2 hours before you go to bed. But
Mhm.
but everyone again is metabolizes things differently, and these are just rules of thumb that have been they're pretty well documented in the literature.
Interesting. Yeah. I mean, and that's a little segue to the next thing is that, I like what your company does, and I had the opportunity to have a trial of that, which I thought was fantastic. So thank you again for that. And we're going to talk about sleep fragmentation. It's really great. So if we can talk a little bit about why it's important to measure sleep, and people got the Whoop strap and they got the Oura ring. It gives them like readiness scores. What their ability is. We can talk a little bit about what the company does, what your actual unit does, the product, and how it differs. That would be great. Then we can go into looking at what I had as the test result as well.
Yeah, no, absolutely. Whoop and Aura and Apple, Samsung, they've done a phenomenal job.
Mhm.
Fitbit,
Yep.
Jawbone was an older company. They've
Oh,
all done a phenomenal job at driving awareness on the importance of sleep, and um, it's it's been super helpful for patients to sort of start understanding how their physiology behaves over time. What Empower Sleep does is we're sort of solving the problem of making sleep healthcare accessible and frictionless for the patient. And we're also, so we're doing that through a telemedicine based approach. And we provide patients like personalized sleep care over a period of time based on their multi night home sleep testing data. And for patients who don't know how the system typically works, is if someone has a suspected sleep disorder like chronic insomnia, restless legs, sleep apnea, their doctor will typically refer them to a sleep lab to go do a sleep study
mhm.
or do a home sleep study, which is a one, and these are both one night studies. And the problem with that is we all know that sleep is dynamic on a night to night basis. We've all had good nights of sleep and we have bad nights of sleep. And if that's true, then guess what? If there's any pathology of sleep, that too will be dynamic. Some nights you'll have more pathology, some nights you'll have less pathology. And so the one night sleep study, although helpful, it never really helped us understand what happens to people's sleep across time in a medical grade fashion. So Empower Sleep lets our patients do longitudinal sleep testing, where we give all of our patients this home sleep testing device. It goes on their finger and download an app. Data goes to the cloud, it gets processed, and they're able to see their medical grade sleep results every morning. It allows us to identify things like fragmentation, like how many micro awakenings are you having during the night. It allows us to identify sleep apnea. It allows us to understand the health of somebody's sleep. And we can use all of these biomarkers across time to then really understand what is the root cause of someone's sleep problem and what can be done to help them improve their sleep both subjectively and objectively.
Yep, beautiful. I mean, a lot of our patients, like, they'll get the CPAP machine, and they hate it. They absolutely hate it, right? They just don't feel that's the answer. Often they don't use it. Um, we get patients where they try to do the in-lab sleep studies. They don't feel they sleep the whole night. So, you then question the information,
Yeah.
the data that's collected, because it is compromised to a certain point. So I love the fact that, you're just at home, and I think you get more information with Empower Sleep than you do with a regular sleep study. And I think that's important. So one of the things I want to talk about is that you guys not just measure, but you have the intervention as well. So you get to work with a team of docs. Can you talk a little bit about that? And I love the videos. You guys had great videos. They weren't long, they weren't boring, they were to the point, and it was very usable and digestible information. So I thought you guys just did a knockout job with the videos.
Thank you, Michael. It's been a labor of love, and the team has been phenomenal. And the thought has been an educated patient is a better patient. And uh, the more educated the patients are, the better the outcomes are going to be for the patient, and the more meaningful of a conversation we can have with them. And so we've like the emphasis on patient education has been pretty strong. Um, and I think the really cool thing here is it's sort of like what you alluded to. People, I can be wearing a Whoop and an Aura, but I don't know what to do with those numbers. Um, like our physicians in our clinic, they can give telemedicine based consultations to the patient, meet with them 30, 40 minutes at a time, or an hour on the initial visit to really understand what's happening to this person in their environment, why their results are the way that they are, and what kind of solutions could work for them. And then we can measure those interventions over time to see how effective those have been. And it's been very formative for me. And it's been very formative for our patients and the other clinicians here. I feel like we've become smarter over time because we have access to so much data, and we're able to sort of uh, understand who responds to what for for what reason,
Mm-hmm.
so like data has helped us become more intelligent, more thoughtful, and get to better solutions faster.
And in understanding the data and the metrics, is there something, how long has the company been around now, with your collecting the data? How long do you think that's been?
We've been around for about 2.5 years, just over
Okay.
2.5 years.
All right.
We've taken care of a few thousand people. We have collected probably close to 500,000 hours of longitudinal sleep data, and which has been really exciting, to really understand how sleep changes over time.
So if you look at it at the beginning, and did you guys have like a hypothesis, like you thought one way in the beginning, but based upon the data has been collected over many hours, is there now something like, wow, we thought this originally, now we think something totally different based upon the data?
Totally, 100%. And when I was in training, we used to think of. I'll just use like I'll use sleep apnea as an example, because you alluded to like the idea of a CPAP, and we've all talked to patients, and we've all like identified sleep apnea, and we've said, okay, the treatment for sleep apnea is a CPAP machine, and patients have received the CPAP machine, and there's some people that do really well. They sort of get it, and like they love their machine, and they're the ones who like tell their entire family of how successful they've been. But there's about a third of people who just don't do well with CPAP.
Correct.
And patients would tell us, hey, I don't like this, I don't like how I feel, but physicians would be obliged to say, no, no, your numbers are, the data from the CPAP machine is okay, continue using it, you'll get used to it.
Right.
And we use this term called compliance, which it's a horrible term, but we would sort of force patients to use a CPAP machine over time, even if they're not necessarily liking the solution, with this idea that you will get used to it over a period of time. And what we've learned, like when you do a sleep study on these patients on CPAP who subjectively feel worse, usually their sleep too is objectively worse. Their breathing might be better depending on how bad their sleep apnea was, but their sleep is objectively worse. They have little to no deep sleep on CPAP, but with mild to moderate sleep apnea, they might have more deep sleep and they feel better. So, what that tells us is okay, like this solution is the wrong solution for this individual, and we need to choose something else. So there are different dental appliances, side sleeping pillows, mouth tape, nasal strips, tongue exercises. There's so many weight loss, with these new
Mhm.
GLP-1 medications. Like there's so many different solutions now available to treat the problem. And 3 years ago, I would not have been having this conversation. But because we've seen how sleep changes over time, how different people respond to different solutions, we can sort of identify these things sooner, jump to a different solution faster, rather than saying, I know we need to try this for 6 months before I say we need to try a dental appliance. Now we can figure that out within a couple of weeks.
Yeah, which is fantastic. We deal with people with some TMJ, so that becomes an issue. People who gain weight, the tongue and tongue placement, that becomes an issue. And when they lose weight, their sleep usually is reported. I'm feeling a lot better. That's great. So if we can jump into, I'm going to add the screen, and we can go over like what the test looks like, and we can talk a little bit about the sleep apnea score, like the apnea hypoapnea index, the sleep quality, oxygen desat rate. And again, as you well know, as our previous conversation, I really thought the sleep fragmentation was something that was fantastic. So I'm going to just add this to our stage here. All right. Can you see that?
Yep.
Excellent.
So you this is the patient web view. The app looks something similar to this, but every morning when the patients wake up, they're able to get their. I'm going to make some changes here, Michael.
Mhm.
Just add some more metrics of fragmentation and REM sleep. Here we go. Here we go. So every morning when patients wake up, they're able to get their sleep apnea report or sleep test report, and it will tell us objectively, what their sleep quality is. It'll tell us how much fragmentation of sleep they've had, what their sleep apnea scores are, how much deep sleep they've had, and how much REM sleep they've had. And having this as a snapshot is helpful, but having this as a trend that's a game changer. And as we're taking care of patients, we'll ask them to try different things. And as they try different things, we'll ask them to journal those different interventions from a sleep aid medication standpoint, from a behavioral standpoint, any other notes that they want to try, take like a peptide or a supplement that's not here. And now the data starts to tell a story under the supervision of our physicians, and patients can start to see what's happening to my sleep apnea. Like we used to think sleep apnea is like if you have sleep apnea, you have sleep apnea. But if you measure across time, what we get to see is like sometimes you don't have sleep apnea, sometimes you do. So if there are times where you don't, then what are the things that you're doing that we can reproduce to keep you in that situation? It's kind of like the idea of a glucose spike on a CGM,
Hmm.
right? Like you don't, that doesn't necessarily mean that you have diabetes.
Right.
If you have, many glucose spikes, but if now that you've identified something, let's see what we can do to mitigate it or blunt it by a lifestyle or a dietary modification. So that's sort of the idea here, is to look at sleep testing data over time to understand the dynamic nature and come up with a plan. And in this situation, you can see that sleep quality is reduced. We can get a sense of a circadian index by looking at the consistency of sleep, and we can also measure fragmentation of sleep over this 7-day window. But in your situation, um, we can also measure these indices over like longer periods of time. And if we look at fragmentation, for example, one thing that sort of stands out is that fragmentation is a little bit high. It's higher than what we would want it to be from a healthy sleep. Let me ask you a question. How do you feel your sleep is?
Depends on that. I can tell you on Fridays when I do my virtual visits and I spend more screen time, it's never great. At least it does not feel that great at all. And I will say, I can clearly say, like, on a Friday, that's when I got to really support with like a melatonin, 5-HTP, L-theanine, that kind of stuff. Because if I don't, Friday night, it's still not great after a day of like being in front of a computer screen.
Yeah.
Right.
I would have loved to see if any of these things were journaled here, then it would have been nice to make those associations.
Mm-hmm.
But maybe that's something we can do over a period of time. Like,
Right.
what's a Friday night sleep versus like a Saturday or a Sunday night sleep or screen time or some of those things. But the whole idea is one can start to understand what's influencing sleep in a positive way or a negative way. On the back end, um, this is what our clinicians are typically using to understand someone's sleep. And what you see on this is the clinical dashboard. What you see on the back end is objective sleep quality in this purple line graph, overlaid with sleep apnea burden, sleep apnea indices in this bar graph, overlaid with the different stages of sleep over the course of time.
Mm-hmm.
And you see on some nights there's as little as like 27 minutes of stable sleep, and on some nights there's almost up to 2 hours of stable sleep, and that's a wide variation. And if we can help you have sleep like this on a daily basis over 3 months, 6 months, or a year, I would imagine that your overall health would be better. That's the hypothesis here. And let's take a look at one of the nights. So now this is a 1 night sleep study. We can see exactly all the information that is being collected from these sensors. And if you want, I can walk you through this, Michael.
Yeah, that would be great, right? So give people the idea, because again, I think you just get so much more out of this objectively, from a data point that can help you to nuance how you move forward as an individual, right? Because not everybody responds to melatonin, right? And everybody knows that when they can't sleep, they go melatonin. And some people say they can take 10 milligrams and it does nothing. I take 1.5, I'm out like a light. So everybody is different, and we look at that from a nutritional perspective, because when you look at sleep fragmentation, I'm sure that would change with what you're eating, what you're drinking, your caffeine consumption, your stress level. And if you can track it, you can change it, because you can't measure it, you can't change it.
100%. 100%.
Yeah, that'd be great to go over this.
So this is a nightly sleep report. Time is on the bottom, so this is like 11 p.m. up until 5 a.m. We have information on movement. So that movement is called actigraphy. It's a graph of activity. You can see it took about an hour to fall asleep, but once you fell asleep, you were pretty sound. There's a little brief awakening here around 2 a.m., but otherwise you're pretty sound sleeper. We have information on oxygenation. We can see how your oxygenation is relatively preserved in the high 90s the entire night. We have information on heart rate. You can see how during wakefulness and during motion, heart rate is much higher. But otherwise, heart rate, you have like pretty healthy, low resting heart rate during sleep. and this is overlaid with your overall sleep architecture. And what we can see that kind of stands out is that you have much more deep sleep in the latter part of the night on this night as compared to some of the other nights.
Mm-hmm.
And there is a decent amount of fragmentation the entire night. And we can talk a little bit more about what that means and why that could be. But let's now take a look at, now that you have a sense of what this report says, let's take a look at some of the other nights here. So on this night, you can see there was some reduction in oxygen levels here. You can sort of notice this here. This fit the picture of obstructive sleep apnea events, but otherwise, like that did not happen the rest of the night. And otherwise, heart rate dipped. You had more deep sleep. Fragmentation was about the same. On this night, you can see how you had much more deep sleep during the night and no motion. This was like sound sleep. So this was a good night too. This is the Monday night after the weekend. Here we are on Sunday going into Monday. Let's see what Friday looks like.
Monday is like a 14-hour day, so it wouldn't be too surprised out like a light.
Yeah, on Friday, you can see fragmentation appears to be a little bit more.
Yeah.
Saturday night was the best. Like you had much more deep sleep and a little bit of awakenings, but otherwise, do you snore?
Not to my knowledge.
Not from your knowledge.
I stayed up all night. I found out I didn't snore. Yeah, dum. Yeah, I don't. I guess if it's like really deep, I might have that deep breathing, but not that kind of deal, or no loss. I always ask people about that. I say, what does your partner's snore sound like? Is that deep? Is that the gasping for air? So it gives me an idea of what's happening. But no, usually do not snore.
Do you have restlessness in your legs at nighttime?
Not to my knowledge. Maybe some of those calf cramps for a while. So I can say like if I don't use magnesium at night, I can say those calf cramps will come a little bit more, or a foot cramp.
Yeah. How's your overall emotional health?
How do we define that?
From an overall anxiousness, mood standpoint, when you're going to bed, how do you typically feel? Do you
pretty good? So I do a little my deep breathing exercise. I do like box breathing. I do the systems body check. Feel the big toe up to the ankle, to the shin, so forth, up to the head. I always read a regular book, not out off a screen. So I try to get like close to a good 45 minutes to 60 minutes with no screen time before bed.
Good. And had you not done the sleep test, how would you have felt like your sleep is, generally speaking?
It's okay. If somebody says, your whole life I've been working on 5-6 hours, my whole life is sleep.
Yeah. So the way we think about sleep is sort of this 3-part framework: quality, timing, and duration. And duration, we use this sort of anecdotal number that comes from population health statistics. Population health, that humans should be sleeping 7 to 9 hours in a consolidated block. This does not take into account measured sleep. It is just reported sleep times. Mm-hmm. So like if you measure someone's sleep and it's like 6.5 hours, I'm usually not too concerned. So your total sleep time appears to be Monday was a good night. Seems to be okay. Like there's a couple of short nights. This is 4.5 hours.
Yep.
But generally speaking, you're like 6 hours total sleep time, 6.5 hours total sleep time. Here was a 7 on Saturday going into Sunday. This seems like a good day for you. So duration, timing is we want sleep to be as in a consistent window. And one of the things that we can sort of gather here is there is a little bit of sort of oscillation in like sleep in circadian timings. And on the Saturday night you went to bed a little bit later, on the other nights it's a little bit earlier. But generally speaking, having sort of a relatively fixed wake up time and a relatively similar sleep time on a consistent basis is one area for improvement.
Mm-hmm.
And then from a quality standpoint, like I can say that you don't consistently have enough sleep apnea to, uh, for one, to sort of chase with a CPAP machine.
Right.
But one could say, hey, like how do things like keeping the mouth closed, tongue exercises, and using maybe a breathe right strip or nose dilation tools like a
Mm-hmm.
mute or a
Yep.
nasal aid or any of those things, like how do they help? And that would be sort of like my next level of experimentation here of let's continue doing what you're doing. Let's see if moving the needle on sleep apnea improves the overall quality of sleep. That's the question. If it does, well and good. If it
Right.
doesn't, then we can sort of explore other things. And it sounds like from a behavioral standpoint, you're already doing the things that should be done when you have the opportunity to do so. But the question becomes, if you do this consistently for 2, 3, 4 weeks, can we move the numbers? Can we move the needle on this? And if it does, then it becomes almost like a prescriptive recommendation. Like, hey, like when you do X, this is objectively better. And if you think it's sustainable to continue doing it, let's keep doing it because it is benefiting your physiology.
Excellent. No, it's great. And I wanted to share this with everybody to see like this isn't just, a score of 82, a score of 79, right? Like, this gives us actually data points that we can change. So we can move this clinical needle forward by some very simple actions. Better than taking NyQuil at night. I still have patients that, to help them sleep, they'll take NyQuil at night, that kind of stuff. And I kind of want to move away from that and have, people really try to do a lifestyle change because, even changing the sheets, to cooler sheets, to making the room darker, to creating a nighttime routine, just as when you have a child, if you have kids, they have a bedtime routine. But most of my patients, they go from doom scrolling, right to bed, and it's not going to bed in a healthy manner.
Totally, 100%. And I think the other thing to be cognizant of is that when you have objective data, that data needs to be contextualized for that individual and the comorbidities that they have. So a person who has, diabetes, systolic heart failure, restless legs, they may not have like healthy their sleep will not fit the normal sleep profile ever because of the conditions that they have to begin with,
Right.
or the age that they are at. Because as we get older, age changes. Sort of like if you were to do a whole body X-ray for me, I'm sure that you would find some degenerative
Sure.
changes because of my age, and my bones they won't look the same as they would when I was 25. And similarly, sleep is the same way. Getting an objective baseline is super helpful. Trying to move it while keeping in mind like we're really trying to improve the symptoms of the individual, and then rechecking maybe every couple of years to see what's the overall health of my sleep over a period of time. And that's kind of the approach here.
Yeah, that's absolutely beautiful. I'm going to exit the full screen here, bring us back here. So can we talk a little bit in your experience, what you see looking at sleep fragmentation? Because when you and I were talking originally, we said, wow, I mean, I can possibly say if you take this supplement and the sleep fragmentation has improved, or if we said, you know what, we're going to stop eating 2 hours before bed, sleep fragmentation improved, I can actually, and please correct me if I'm wrong, use sleep fragmentation as a data point, a metric to determine that if what we're recommending for them to do is actually helping or not from a supplement perspective, a nutrition perspective, an exercise perspective, an environment perspective. Is that a correct way of thinking?
I think so. Yeah, that's how I think of this. And again, like we're learning about this because This is something that we haven't done for a very long time. And the thing that we need to be cognizant of is just because what we can measure is only the things that we can measure. I'm sure that there's other things in the background we just don't have the ability to measure. So I think understanding the clinical symptomatology and how one is feeling is also a very important component to the story that the numbers are telling us. And but you're totally correct. Like, I would measure these numbers over extended periods of time, and there is so much night to night variability that typically happens that using something for 1 or 2 days is probably not enough time. But
Right.
maybe, like, a month or 2 months, and checking doesn't have to be on a daily basis, but relatively frequently, to see what happens, while also having the conversation with the patient of like, hey, how do you feel now as
Right.
compared to before? And the problem with fragmentation is, how, like, when you order an X-ray and the radiologist says it's an infiltrate. What, man, is it like cancer? Is it
Right.
pneumonia? Is it heart failure? Like, what is the reason for infiltrate? Fragmentation is a uh, very non-specific, hypersensitive way to measure, hey, that there's more than usual arousals in sleep of your autonomic nervous system. And those could be from like pain, they can be from reflux disease, those could be from anxiety, those could be from sleeping in a new environment. Things as non-sleep related as that, to things like sleep apnea, restless legs, and all of the other sleep disorders that kind of exist.
But and my push to that is like, but if we can collect data over a period of time, then it's great. Because often we'll see the patient comes to the facility and they say, "Hey, my doc said that my blood work's absolutely normal, all my tests are normal, and I feel horrible."
Yeah,
Right? So we want to say, okay, well, that's just a data point. So now we're going to look at these other data points to see what we can do to make you feel better. And sleep
totally.
is often one of those that is overlooked. Unless the patient comes in primary care and says, "I'm having a sleep issue," it's an overlooked thought process, right? So that's why I think this is great. So one of my patients asked, well, you put the ring on, and what is it collecting? How it goes to the app, but what is it looking at? So that's one of the questions that she had, and you talked about this. I think let me get to cardiopulmonary coupling, right? So if you can talk a little bit about how this actually works.
Yeah, that's a great question. um, I'll answer that uh, with some background information. uh, you know from the pulse rate, from the pulse, we can estimate heart rate. uh, these sensors have a little red light built in them, and this light is able to sense density, and it's able to measure how much volume of blood is at the fingertip, beat to beat to beat to beat. Okay, so with this, like, beat to beat variation, we can understand one's heart rate. We can also understand heart rate variability. Uh, what we also need to be aware of is that as we breathe with inspiration and expiration, there is an oscillation in the amount of blood, the amount of, it's called cardiac output, the amount of blood that the heart beats with each breath. So, because through this same signal, we can measure heart rate variability, we can also measure respiratory rate and respiratory rate variability. When you have these four parameters that one can measure, we can work backwards to say, is this person awake based off of their cardiopulmonary pattern, or are they asleep based on this cardiopulmonary pattern? And if so, what stage of sleep are they in? Because our autonomic nervous system behaves very specifically in specific stages of sleep. Like REM sleep behaves very similar to one being awake, except there's no movement, while deep sleep behaves in a very systematic, reproducible, like breath to breath uh, variation. Is Each breath is very similar to the one prior. Each beat is very similar to the one prior. But while in light sleep, there's a lot of variation that may happen. So because we understand physiology so well, we can then use algorithms to understand what stage of sleep one might be in and what is actually happening to their physiology. And these sensors can do that in a pretty good way.
Gotcha. Yeah, again, I was really very impressed with it. I really enjoyed it very much. It was easy. It was so easy to use, right? You just download the app, put the ring on, go to sleep. It was really really simple to use. So can you talk a little bit about like when you take somebody through a process, right? So when would they meet with your physicians? Do they meet weekly? If they need something like an appliance, do you guys provide that? Can you walk us through that?
Yeah, no, we initially start off with like a very comprehensive 1 hour intake visit to make sure that we can help them. We'll then start off with 2 weeks of testing at a baseline. And whatever downstream care they need, we will coordinate that. We have a repository of dentists nationally that we've curated that we will refer the patient to if they needed an oral appliance, and then we would retest to measure the efficacy of the dental appliance, and we'll work with their dentist. We work with ENT surgeons locally where the patient is to see if there's anything mechanical that can be done for sleep apnea. If they need a CPAP machine, we would order it and it would be billed to their insurance and we would be delivered to their home and we would continue the aftercare. So for the patient, we try to think of it as virtual first sleep care, but the goal is to provide care through the entire spectrum until we feel that the patient has been successful and the patient feels that they've been successful.
Gotcha. And they and then the testing is throughout however long of the course they stay with you, right?
Yeah, usually 3 to 6 months. I tell patients that for most people, it takes. Some people come to us just for a diagnostic study for 2 to 3 weeks. Some people, but most people, after they see what their sleep is like, they will allow us to take care of them, and it takes about 3 to 6 months to make their sleep as optimal as possible for them.
Gotcha. Super. So you've done a bunch of these podcasts before, and again, thank you for your time. And this is really great. Of the interviews that you've done, what do you think is the one question somebody should have asked you and they didn't ask you?
Mm, that's a good one. That they should have asked me and they haven't, huh?
I'll ask you this.
Yeah,
How
you
do you-
still. It's probably. Yeah, I don't know. It's a good question. Well, yeah, you stumped me right now.
So, that's right. So how do you sleep? I'll ask you that.
My sleep used to be really good. Objectively and subjectively sleeping. Generally speaking, I'm a pretty good sleeper, but we have 3 kids.
That's great.
Seven,
You're not,
6, and 2, and we have like a young growing startup that also behaves as a child, and we have a growing team, and I think about what we do a lot. We put a lot of, we want to be as thoughtful as possible, and so my sleep is decent. It used to be better. There's like a lot of clear triggers, and when I correct for them, then my sleep is objectively and subjectively better. But generally at baseline, like I have pretty good sleep glue, as one of my attendings used to tell me. Like my sleep is pretty cohesive to begin with, and it's more resilient than it is probably for other people.
that's fantastic. And do you have anything special in your room? Do you have the special sheets, the cooling sheets, the dark, the blackout, shades
Oh.
and all that? And
If I told you how we slept, so we have 3 kids, and I don't know, somehow we just got into this habit of like sleeping together on the same bed.
yeah,
And so like one kid is one way, head is on this side,
yeah,
I'm
yeah,
on the other side, the other kid is the other way, and the baby's on with me next to me. So
yeah.
yeah, if you saw my sleep environment, it's kind of a nightmare, but we get through it. And um but generally speaking, I think if someone is a good sleeper, they're usually much more resilient.
For sure.
Where one needs help is if they don't have good sleep, then one definitely needs to make changes to overall environments and behaviors. And one thing that we have done that I'm quite proud of is uh, making sure that everyone gets up at the same time, and making sure that there is darkness in the home regularly after the same time. I think that is something that has really helped all of our circadian rhythms be relatively entrained. That's something that I would say recommend everyone to do. Like, having consistency of sleep and wake up times is probably the strongest lever that you can pull, assuming your sleep is relatively healthy.
Right.
And but yeah, no, they'll sort of stop there.
I mean, I tell my patients, listen, when you cannot wake up and go to your phone, right? I think that's probably one of the worst things you can do from an emotional perspective, but also from a sleep wake perspective. So I think you should, not even have the phone in the room unless you absolutely have to. And give yourself at least 30 minutes before you even start looking at that damn thing. So that's for sure.
100%.
So you can share with everybody real fast, how do we get to Empower Sleep?
Yeah, just go to empowersleep.com, EMPOWERSLEEP. There's an icon that says Fix My Sleep, and it's a pretty self-explanatory sign-up process. You can upload your insurance, and we'll process it and get you plugged into the clinic, as soon as possible. Usually we can get patients in pretty quickly, usually within a week and 10 days, and the sleep testing thereafter. And we look forward to taking care of anybody who has a possible sleep condition that they've been struggling with.
Yep. Yeah, no, this is great. And again, we in our office, we see a lot of the gut dysfunction. We'll see the cardiometabolic, and you can work on these great things, autoimmune. But if we don't dial in sleep, we never really move ahead, right? And we want to dial in that sleep so we get that resilience. So I really, really appreciate your time tonight. Thank you very, very much. This was great. This is going to go onto our YouTube channel, so everybody will get to see it again. We'll see you soon.
Thank you so much, Michael. We'll stay connected. Bye-bye.
You got it.